of Housing Adult Social Care Scrutiny Committee. We'll start with apologies because then it'll make sense of why I'm here. Councillor Danny Myers is unable to attend today. Councillor Kelly is being substituted by Councillor Burton. I think that's it, isn't it, in terms of apologies?
Yeah,
that's what I see, yes. So the first item is, the next thing is the declarations of interest, if anyone has anything they wish to declare.
It's not a declaration of interest, but it's just to say I need to leave before 7 o'clock. So about 10 to 7. Unfortunately, if we're still going, I will get up and walk out.
Okay, thank you for that. So next on the list, I need to just tell everyone where the exits are before we move on. We'll all go out that way if there's an emergency, and the toilets are, I think, 1 or 2 doors down on the left, so that everyone knows where the facilities are. We now move on to public participation. We've got 3 registered speakers. The first one is Flick Williams, who wishes to speak on, I did have this somewhere, issues pertaining to the remit of the committee. Are you there, Flick Williams? Maybe we'll move on to the next speaker and then come back to Flick Williams later. So in which case I'll call on Jonathan Beatson. Who again wants to speak on the remit of the committee. Welcome. You have 3 minutes to address us.
Yeah. So thank you very much for having me to speak. I've had a social worker all my life since I was a young kid. I went through a most horrendous time, the support accommodation where I was sexually raped. I had no social worker. I suffer from mental health conditions. I've had to go through an assessment. I can list them, but it's a long page. And the social worker did a lot for me in my childhood. They were there for me. I don't have that contact no more. There's lack of funding, and what frustrates me about it is that I'm open to open duty, but it's just different person. I don't have the consistency. My auntie is doing the social worker side. She's 80 years old doing a social worker's job. And I got trapped in the mental health system where I wouldn't be seen. We had to push for me to be seen. I ligatured. I threatened to jump off the bridge in the River Ouse. I jumped off my auntie's house, fractured my back. And it's just, there's no consistency. Now, if I had that, I wouldn't be here today, because I am getting sick and tired of being open to duty. And people say, you're okay, you don't need one. But look what happened at Harlington. Look at my past. I got abused in my past. I lived in horrendous conditions. And I can't, the words are so shocking that I'm here today, because I could have that contact with the social worker and they would be there to fight my corner. Do I have that consistency? Do I have that? No, I don't. I don't have that because it's lack of funding. I had a review done. They took it to the management. He don't need no social worker. That's what management said. But the past is playing a toll. I can't hold a job. I'm a type 1 diabetic.
I'm going to have to ask you to wind up, but what I want you to know is that we've all been listening very attentively.
My question is, what is the solution? What is the solution to the funding and everything that I've said? Because it's sick and tiring of this all.
Thank you. I'm sure that's taken a lot of courage, I can see, to come and say all of this. As I say, there are people listening here who I'm sure will take it away and get back to you to try and advance this situation. Thank you. Our next speaker is Jeff Beacon, who wants to talk about provision of housing.
So I'll be very moving. I'm sure the regular is back for him.
You two have 3 minutes, Jeff.
Thank you. The Office of National Statistics calculates that 60% of national wealth is land value. The value of UK farmlands, forests, moors and mountains is just a few percent of this. The greatest value is that of the 6% of land that has buildings on it. By itself, the value of this land is vanishingly small. It is the right to site buildings on this land that gives this 6% its value. Using ONS figures, these property location rights amount to between 56% and 58% of UK national wealth. This vast store of wealth is controlled by the planning system. For several decades, it has encouraged house values to soar, benefiting property owners and penalising those who rent. In the UK and in York in particular, this has enormously increased the wealth gap between the poor and the affluent, and between the young and the old. Planning is enslaving the poor and the young. Authorities that control the planning system are able to improve the situation if they are supported by national government. But have they the will? In York, it would mean revising the local plan, now over 5 years old. Its current proposals will clearly cause an increase in inequality. Recently, there's been more awareness of climate change, including the need to live low carbon lifestyles. The House of Commons Science and Technology Committee has said, in the long term, widespread personal vehicle ownership does not appear to be compatible with significant decarbonisation. Cars, including electric cars, are not part of low carbon lifestyles. This has enormous implications for physical planning. We should be planning for more or less car-free living unlike the proposed developments in the current York local plan. This plan will increase carbon emissions. It was introduced over 5 years ago, and it's time for a revision. As far as I can see, this committee has no serious intent in its work plan, sorry about this, to understand housing inequality or climate change. It's about time you did. Thank you.
Thank you, and you came in at just 3 minutes. Flick Williams is there. In which case I call on our last speaker, Flick Williams, to address us. You have 3 minutes.
Good afternoon. Sorry about the technical difficulty. Year 5 of the pandemic and a status quo of you do you firmly established. Those of us who are either immunocompromised or clinically vulnerable, now well used to living extremely restricted lives, protecting ourselves as best we can with the tools available, respirator masks, HEPA filters, and largely self-exclusion from society. But that only works up to a point, and on 29th of April, I found myself in the long-dreaded situation of emergency admission to hospital by ambulance. The first 23.5-hour wait, yes, you heard correctly, in A&E, manageable by positioning myself next to the main entrance to the department and the constant air change by swishing automatic doors. Once in the inner labyrinth of assessment bays, surrounded by a cacophony of coughing, with the power on my portable air filter rapidly discharging, rather less safe. All patients were being tested for MRSA, for COVID not so much. No healthcare workers were masked, not even with surgical masks. Once on a ward, I refused all food and drink, making it clear that this would involve removing my FFP2 mask. I repeatedly said that I had had an anaphylactic reaction to my first AstraZeneca jab and was therefore not vaxxed and relaxed. And then on the 4th day, I was directly exposed to a COVID positive patient who was refusing to be confined to a side room and wandering the ward against the protocol, which was excused by, he's not going to touch you, he's probably not still infectious by now, and we'll pull the curtain around your bed. Well, COVID is airborne. The World Health Organization says so. If with you in person, I would now be piling reports in front of you as evidence that COVID is a vascular systemic disease affecting all organs, brain included. Long COVID, the high stakes risk of every infection. So whilst public health busies itself with childhood obesity and advertising at bus stops, adult social care is buried by a tsunami of demand, and the healthcare system, both primary and secondary, exhibits more and more signs of being broken beyond repair. My questions are these. How is any of this sustainable from a worker's perspective as well as that of patients? Whatever happened to the principle of first do no harm? Where are the risk assessments? Where is the safeguarding? How does any of this meet the city's goal of reducing health inequalities, or does that only apply to those citizens who do not yet have underlying health conditions? Is it both ableist and ageist? Good health is a temporary situation for everyone. The amount of hospital-acquired infection and death is nothing short of scandalous, or are we in fact, by default, operating an unwritten policy of eugenics? Thank you.
Thank you. Thank you for your comments, and they will, along with all the other comments, be considered at this meeting and in due course. That concludes all the public participation. So we now move on to, I need to remind everyone that it's a webcasting of a public meeting and that everyone is expected to behave courteously. I think that's all here, and now we'll move on to our next agenda item. Which, yes, so I now call Sean Macy, Angie Walker, Michelle Carrington, Liam Goodwin. Liam Goodwin is joining us remotely to present the item on adult autism and ADHD assessment series.
Actually, there was to join on the line, which might be able to make that just so.
Yes, yeah.
And family issues based on.
Thank you, everyone. Good afternoon, evening. When did it become evening? I'm never quite sure. My name is Michelle Carrington. I'm the Director of Nursing for York and North Yorkshire in the ICB. And I've been part of a group of people navigating our way through this very difficult issue, I think, of managing an extensive waiting list and ever-growing waiting list, and what we might do to best support people while they're waiting, and also to try and manage that waiting list. I'll let my colleague introduce himself.
Yeah, hello, I'm Sean Macy. I'm Assistant Director of Primary Care and Pathways. Thank you. At York Place in the ICB, similarly, I've been working with Michelle and the team on trying to move forward with this agenda around our ADHD and autism waitlists with our specialist provider.
So we come to you really this evening with an open heart and open mind, asking as trusted partners for your views and your input into the next stages of what we should do. Hopefully you'll have read the paper. Would it be helpful if I gave you some highlights of where we've got to? Yeah, great. So,
Can I, just before you do
Of
that,
course.
can I simply say, because it's a public meeting, one thing that concerned me when I saw the report was there wasn't, in the simplest of terms, a definition of what we're talking about. If there's just a few sentences so that anyone watching can actually see, what do you mean by adult autism? What do you mean by ADHD? To give context.
thank you, that's helpful. Happy to do that. So both ADHD and autism are neurodevelopment disorders. I don't personally like the name disorder. Conditions, and that are diagnosed by a set of criteria by clinical specialists. And I'm not a clinical psychologist, so wouldn't ever diagnose somebody with that. And diagnosis comes to people at different times in their lives, if it does at all. And I think as a society, we've become much more in tune with the possibility that people who live their lives as they do might be neurodiverse. And sometimes, certainly through the publicity, we have people quite old in age who are beginning to question whether they do have a diagnosis. So for lots of different reasons, we have seen nationally an exponential rise in people being referred for an assessment. For us locally, we have a really impressive provider in the retreat who was becoming completely overwhelmed really with the increasing waiting list. And the commissioned service, as it was then, has quadrupled really in terms of the demand on that service. And as it's a CQC registered provider, there is particular risk for providers in not being able to manage that waiting list and therefore meet the standards of their regulatory body. And so we knew there was a real risk that they might hand back the contract, and we didn't have any other providers to be able to pick that up. So we worked very closely with them to try and work out a way that we could keep people ready and waiting for an assessment that's ever growing, but also change the way that we did it so that it wasn't done in chronological order and that it was done based on need. And that isn't any different really to any other waiting list. So if you got referred for your hip replacement as an example, the hospital that you got referred to that accepts you on that waiting list would have a determined waiting list length. And also you are now clinically triaged and clinically reassessed in order to know where your point is on that waiting list. And it's not done in chronological order. One of the other things that we wanted to do, so we had to do that really quickly. What we did was introduce a set of criteria, which was red, amber and green. And so those on the specific list for priority went through to the retreat, and the rest were held on this holding list, as it was then called, on an online platform. We had to do that quite quickly for the reasons I've just explained. And we absolutely hold our hands up to say that we could have done public engagement much better than we did at that point. That's everybody's view. Absolutely it is. And as we then move through a pilot of testing this out, we've then done what I hope you will get assurance around, an extensive programme of public engagement. And I've worked very closely with organisations such as the York Disability Rights Forum and others to further develop and really listen to what this community was saying to us. And I think it's fair to say, I think we've taken the lid off that, and everybody's been very, very open and honest about their views. And I think some of the feedback has been hard to hear, but it's also been representative of what it's like to be living with a condition which might not be diagnosed and where you don't have much help while you're waiting. So we've tried to do both things really, is to manage the feedback that they were telling us to move on to the second phase of the pilot. And the second phase of the pilot is that we get rid of the red, amber, green, far too confusing for people, go to urgent and routine like you would for any other waiting list really. Just absolutely nailing down the clinical criteria for urgent with the retreat. And then the GP and community mental health teams can refer you urgently onto that list. And then everybody else that's routine goes onto the online platform. And the online platform is held, a waiting list on the online platform, the routine is held by the ICB. That allows the retreat to manage that waiting list, triage people that are urgent, and be able to manage that within their workload. I listened to the retreat last week describe the impact, I think, of what it was like before, having this enormous waiting list that wasn't needs-led, that didn't have a priority criteria, and holding the risk of that, and then finding out sometime later that perhaps you should have seen somebody earlier, but you didn't have any idea really that they needed to be seen sooner than somebody else. So I think there's lots of benefits of the way that we've been doing it, but there's still a lot of work to do. And we come now at this point in time because we don't want to stay on a pilot forever. We want to make a decision about what service can we and should we provide in this area. We've also been talking really closely with the Mental Health Collaborative, which is what it says on the tin. It's a collaborative of our current mental health providers. What we hope that they will be able to do is get comparable data, because I know you're going to ask us, how do we compare? And that's really difficult. Even nationally, that's very difficult, except to accept the waiting lists are growing. And that they would hopefully be able to, by the end of the year, be able to navigate how the ICB as a whole might approach this in line with what might be happening nationally as well. So I suppose that's the summary of where we are just now. I'm really happy to answer any questions or concerns that you've got. I know we've got quite late in the day and happy to respond as much as we've done. I hope that that's answered some of your questions. Today you sent us some questions, but really happy to see if we can answer any more.
Are there any other points that you would like to make, Sean, or that Liam Goodwin would like to make remotely at this point, just before we get questions?
I think I'd just reference the fact that in providing the online platform, the intention was really to give people some pre-diagnostic support, which I think was absent previously. So we recognised that right at the start of the pilot. I think people have different opinions on the value of that support, and people have very different needs who are accessing this pathway as well, which we absolutely understand. But just to kind of emphasise that we've done that with the best of intentions, and I think there's probably still some work to do in terms of how we provide that pre-diagnostic support and post-diagnostic support. But we'd welcome any suggestions in terms of how we approach that, whether we do it digitally through the platform, whether we can do it through community groups. So yeah, any suggestions welcome. Thank you.
And I think the overwhelming feedback from all the engagement that we've done, which has been extensive, is that the two main messages are: we want to remain on a waiting list. However long it takes, it's important for me to stay on that waiting list. And it's great that I can work towards getting some support while I'm waiting, which wasn't there before. So the support bit and the being on a waiting list is still very, very important to people.
Thank you, good. So I've not heard that Liam Goodwin has anything to say at the moment. Is that? That's okay, so fine, okay, so I'll throw it open to members. The thoughts, yes, Councillor Runciman and then Councillor Street-Walsher.
Thank you, Michelle and Sean. I remember the Health Watch report very well, as I'm quite sure you do. And I've got quite a few questions, but I'll just ask the first of them. I am concerned about people that are digitally excluded, and that comes in your report. And I'm also concerned, aligned with that, about people who find an online portal difficult to navigate. And I've had a report from a resident very recently saying a 22-year-old young man found it extremely stressful recently, February, to do that. And I'm wondering if you're going to do something about, first of all, the digitally excluded, and secondly, about getting some sort of user testing, particularly from young people, to make sure that they can input the information that you need to do what obviously does need doing. That's the first of my questions. And would you like to tackle that one first?
So shall I pick that one first? So in terms of the digital access, yeah, we absolutely recognise that that's come up as an issue. And our proposal going forward is that we have a referral support team upstairs who work with us on all of the health referrals and basically have a conversation with patients around choice, help to direct them into the appropriate clinics and manage their referrals into the hospital. So the proposal is that anybody who doesn't wish to use the online platform can ring or email that service, talk to a human being and get their referral put onto the system with the support of the referral support team. So that means that anybody who feels as though they're potentially digitally excluded can pick up the phone or send an email to a person and get their referral logged in that way.
And also the main difference through the first part of the pilot and where we want to get to is that you had to go through the online profile to get referred. And now what we're saying is you absolutely don't have to do that. It's a choice. So if you're an urgent referral, then your GP or your community mental health team will do that. But if you're routine, you don't have to do it via the platform anymore. It's not mandatory.
Oh, right, okay, so Angie, do you want to come in there? Oh, Liam wants to come in. Liam, sorry, yes.
Hi there, Liam Goodwin, currently head of service at the retreat clinic for our autism and ADHD service. I just wanted to kind of reiterate some of the points around the digital exclusion. What we have also done at the retreat in previous is have a separate referral form that can be sent direct to us from a GP. We do also employ staff who have and do support people over the phone to be able to fill out those forms if needed.
Thank you for that. Okay, I will, unless you've got a follow-up. Yes.
Then I'll
Yes.
say that later. The other thing I remember from the Health Watch report is people saying that when they had completed the app, nothing happened. And that is a big worry.
Yes.
One of the great things that happened in my time as executive member was people knowing that if they thought they had dementia, they could get support before they were diagnosed. And I think that is really, really important. People need that support. Families need that support. Now, have you put in something that actually picks up those people and doesn't just let them fill in and then it all stops?
Yeah, certainly the plan is with the proposed changes to the platform, which involve taking off the acceptance criteria, removing the red, amber, green rating. We're not using that platform as a screening tool. So the platform will be used purely to register the referral, to provide some functional support for people if they wish to access that. And they can also fill in the About Me profile, which gives them some kind of personal information to try and support them while they're waiting. So I think we are trying to address that. Plus, everybody should get confirmation that their referral has been logged onto that platform now, which I think you're absolutely right in raising that, because I think people before were just completely unclear as to what the status of that was. So in addition to that, with the changes which we're about to implement, hopefully in the next month or so, we will be involving some members of the community to test those changes as well. So we are keen to involve people to get feedback on the changes that we're implementing and how the platform feels to use for them. Yeah.
Thank you. Councillor Stillwater.
Thank you, Chair. My comments do follow on from Councillor Runciman's. It's about the diagnostic questionnaire that people have and I think a lot of the feedback was around that they didn't understand what it was and that they were getting a diagnosis or they were going, or that was going to be their way into diagnosis. And I wondered there if there was some sort, if the people referring them in hadn't actually understood what it was in, like, what would be the support, what would be the follow-on after doing this questionnaire. And I wondered if there was some more training around professionals understanding actually what this was and where it could lead, and managing people's realistic expectations of what could happen from this.
Yeah, I think that's a valid point. And we've got a lot of work to do with our GPs and community mental health teams. There have been quite a few changes throughout this past year in terms of the platform and the referral pathway. So I think what we're trying to do is make it as clear as possible for people who access the service and our community mental health teams and GPs in terms of helping people understand what the pathway is. So yeah, absolutely, point taken.
Thank you. Well, go ahead, councillor Runciman, while we're waiting.
This is a tricky one. I've had a message from somebody whose son was getting an assessment, adult son was getting an assessment while she was getting divorced. And the judge in the divorce court said, oh, that online assessment isn't an assessment, so I'm not going to count it when I'm looking at, I would assume it was financial responsibilities for the adult child. Now, how on earth can you solve that one? Because obviously the judge in a family court, I would assume, didn't understand that that was the way in.
Yeah, I take your point, Carol, entirely. And what I would say is I think the country and the world still has some way to go to accept neurodiversity as very normal for those people and how they fit in society and what support we could wrap around them. And I think this is why some people feel that they need a diagnosis as well. And they've said that very clearly because it's the gateway to things like benefits, suitable adjustments for employers, whereas we want to get to a point where your needs are met despite your diagnosis, because it might take you a long time to get it. You might not want a diagnosis, but you still have needs that need to be met. So one example I can give you more locally is that you would have had to have had an assessment and diagnosed as such in our 2 local universities to be able to get suitable adjustments. Now, through conversations and through this work, our education providers are much more open and willing and have understood a lot more about the needs of these individuals and are willing to make those suitable adjustments while they wait for an assessment. And that's where we need to get to.
I think we
I
have
heard today that that young person had ended up in A&E and is having an assessment next week. That is not the way to do it.
No, I agree.
Right, okay, so we have Liam Goodwin wanting to come in.
I
Liam?
I tried to kind of touch on that point that's just been raised there in terms of the actual access. And obviously over the past year, there has been some confusion around some of the communication, but there has always been a direct referral route to us as a provider. So alongside the platform since March in 2023, there has also been a direct referral route into our services for urgent or expedited referrals. So some of those circumstances could be things such as court cases, a certain healthcare treatment, and it's usually determined at the point of when that person goes to their referrer. So if they go to their primary care physician, some people might direct into the platform, but over the past year, we have always had a direct referral route to us, which would usually be marked as urgent. And in that case, we would effectively expedite an assessment for that particular person.
Thank you. So now we have Councillor Cole. To say something.
Thank you, Chair. I just thank you to Michelle and and Sean and others from the ICB. And I know that there's been this has been quite a long journey and a long process, and you've come a long way, which we're very grateful for, particularly in the last year or so. I just wanted to ask, obviously we know that you said at the beginning in some of your remarks about you are not a professional in this field. I think when we've spoken previously, you've said that this work is normally carried out, diagnosis is carried out by consultant psychologists. There is a national shortage of consultant psychologists. I just wondered whether you could set out a little bit more where we fit in terms of how bad our shortage in York is in terms of clinical and consultant psychologists compared to other parts of the country, and also just what you're managing to do with the changes that you're making to make the most of the resource that we do have, and anything that we're able to do to recruit or, get more consultant psychologists in the future.
Yeah, and I think it would be good if Liam wanted to come in on what it feels like to be working in a service that requires.
It's very difficult for me to comment on any other providers within the country, but from our perspective, we kind of are at capacity in terms of what our funding envelope gives us as part of our contract. So currently, to give you a bit of an idea of the makeup of the team, we have 2 clinical psychologists within the team, we have 3 occupational therapists, 2 assistant psychologists, we have a lead nurse, and we have 3 consultant psychiatrists as well. And that makes up the bulk of kind of what our contract allows us to have. We do also have a big business support team in terms of admin resource, as well as 2 service managers that sit alongside each other to manage both the autism and ADHD service. I can't really comment in terms of, as I say, other providers and what their recruitment issues are, but when we have had changes in staff, we have found it difficult to bring in psychologists, psychiatrists, and I think one of the impacts that we have seen is, it's not kind of an excuse going back to kind of COVID, but we have seen a lot of people go into kind of individual practices and kind of working in their own kind of environments as opposed to working for organizations. So at times we have relied on sessional staff. We do have a big pool of sessional locum staff that we can go to if we need them at the time. But our core team is kind of maxed out in terms of our capacity and what our funding allows us to facilitate in terms of those staff models.
And I think what's been described there is very typical of other commission services that we see. And the requirement for clinical psychologists has grown in my lifetime because people recognise the real value of psychological care. For example, the children's home that we've just opened in York, we funded a clinical psychologist with partners for there. Doesn't mean it's easy to recruit one, and it isn't. And we're doing that through our local mental health provider, and they're struggling as well to get clinical psychology. There are clinical psychologists in the acute trust who, for example, might look after somebody that's diagnosed with a long-term condition, such as had a stroke, and they get post-stroke psychology. But we have seen an exponential rise of private practice of clinical psychologists too, which I think has given employment opportunities for those psychologists, but have depleted the NHS on the back of that. What I can't tell you is what the workforce projections are. Those that work in workforce more full-time than I do would be able to tell you how it kind of looks for our ICB compared to others. I think it is a national issue.
Yes, I think Liam wants to come in first.
I just wanted to, again, just clarify a little bit more about that. We do kind of model our staffing based on the different elements to the service that we provide. So obviously when it comes to our diagnostic assessments, we do have to have more specialists such as clinical psychologists or consultant psychiatrists. But we do also provide things such as medication for ADHD, as well as post-diagnostic support for our autistic clients as well. In those cases, for our autistic clients, our groups and individual provision that we provide as post-diagnostic support is run by experts by experience, peer mentors, coaches, people with lived experience. And we do have quite a high makeup of a neurodivergent team as well. So yeah, we do model it based on kind of the elements to each individual pathway within the service.
Yes.
Thank you. Sorry, just one very quick follow-up, which was just really, we know that, it's in all of your reports and previous reports about the waiting times and the numbers of people coming through these pathways. The thing I was trying to ask about was whether there had been an impact of the changes that you've managed to make in terms of how many people you're able to see, and whether or not you're able to kind of change around the roles that people do, whether they're supporting people who already have a diagnosis with support and ongoing support alongside the people who need new diagnosis, and just whether there's anything that you've managed to change in that system that's managing to make what is, let's face it, you know, we don't have enough resource in this area. We don't have enough resource across the country in this area. But actually, I think you are making some really great strides at trying to make what we do have go as far as it possibly can. And I think that's, you know, it's really important. And I think it's really welcome progress that you've been able to do that.
A few short points I'd make is that some organisations may have closed their waiting lists due to the demand because they can't cope. And we chose not to do that so that we could truly see and measure how many people required to be put forward for an assessment. And we probably haven't reached the tipping point of that yet, but we've got a much better idea of what our demand is. We can't say the same for the rest of the ICB even, because we manage this in very different ways. So at least then we can lobby, and we do nationally, for this seems to be the demand. So the prevalence data that's in the report is an example of 1.1 of the population being prevalent for ADHD. I think it's likely to be much higher than that. And so we will be able to better understand that. As well as the length of the waiting list rising, what we've also seen is, you know, the more assessments you do, the more positive diagnosis you get, the more people get put on ADHD medication, and they need a specialist review every year. And they've taken up nearly half of the capacity that we put in to do the assessments. So immediately that went down. And so we're doing a couple of things around that. And again, if Liam's still here, he'd probably be able to talk more eloquently than I. But the retreat themselves have been trying to do some transformation so that they can do the assessments in a much shorter time. And I've been testing that out. So it's gone from sort of 9 hours of assessment time to 2. Therefore, you can see more people. And I've definitely been thinking about how they use their workforce much more flexibly in order to do that. And then we as an ICB, working with the LMC and our primary care colleagues and the retreat, have been looking at, could we do medication reviews in a different way that releases some capacity from the retreat to do more assessments. So there's quite a lot of transformation work that's going on at the same time.
Liam would like to come in, and then Councillor Baxter, I know you've been waiting very patiently.
Yeah, I'd just like to kind of pick on some of the changes that we've made internally from our point of view. So from an ADHD perspective, our actual assessments are quite short. They always have been, because we use a consultant psychiatrist. But as Michelle and Sean have rightly said, that a lot of our impact at the moment is ADHD medication. As a specialist provider, we are the ones that do have to monitor that specialist medication every year, annually. And what we have seen over the previous months is a medication shortage. And what has happened is, from primary care's perspective, because they're not specialists, they've been referring much more directly to us. So our demand has outstripped capacity considerably. So our ADHD assessments are slightly different. What we have done on our autism side is, as Michelle rightly said, is condensed the assessment. We've using multiple clinicians in singular appointments. What it's allowed us to do, we have increased capacity to a certain level, but it's not meeting the demand, if that makes sense. What we are seeing now, though, is more consistent numbers, and what we're getting is a much better, much more pleasant client experience. Previously, we had a pathway that was quite inflated. It would usually take 3 or 4 appointments to be able to diagnose somebody and provide them with a feedback and a report. What we do now is we do have a singular assessment, single appointment for somebody who can come to the assessment, see a couple of our senior clinicians, and potentially walk away with a diagnosis or a non-diagnosis, which gives a much better client experience and more consistent numbers.
Thank you for that. Finally, Councillor Baxter.
Michelle, you sort of touched on it a little bit about working with the universities in the city, and I think, you know, I found that I've had a couple of residents contact me because they've just not known even where to start in getting a diagnosis for sort of autism or ADHD, and also waiting so long to get them. So I just wondered if you could go into a bit more detail about how closely you work with the university, because I know that a lot of students just can't get the provision that they need, both with, you know, assessments, medication, just sort of a variety of things.
Yeah, and this is why I think we want to really push on the pre-diagnostic support from the whole community. And that's where we want to focus our efforts going forward, accepting that the waits are not going to be addressed overnight. So there's much more work to be done. We want to have a hub. We want to be able to get funding, which does that. And we want to be able to reach out much more to employers and our educational providers to do that in a much better way. And that's why we are really open and willing and wanting to work with people like York Disability Rights Forum to be our partners in designing and developing what that should look like going forward. I don't know if you wanted to add anything else about our plans, but what we have done is go to the ICB exec with this paper and plans yesterday. And we have pushed on the fact that actually, you know, we really do need to push on getting a consistent offer for pre-diagnostic support with voluntary sector, with education and with our employers. The pre-diagnostic support can't just be provided by health colleagues. We're not the best people often to be able to do that. Absolutely not. You know, designing material, looking at the pathways through, getting the communication right, needs to be done in conjunction with the neurodiverse community. So.
Yeah, just to add, we have done work with York University and York St John, and they are now accepting the outputs from the online platform to help students have those reviews around suitable adjustments in terms of, so that feels like really good progress and something that we could really push a bit further and work a bit more on. So that feels like a success story, at least from the platform. So yeah.
Councillor Rose and then Councillor Pepper.
Thank you, and thanks very much for being here and for meeting with us here and separately, for reading, responding to lots of questions, all the workshops you guys have been doing. Thanks to all the other people in the ICB retreat, Health Watch, YDRF. I know it's been a huge undertaking the last year to try and listen to everyone. And thanks for acknowledging the issues, that lots of those implementations were rapid, that things like the RAG system didn't really work out, that communications and clarity weren't great, that the tool was not good for triaging, that the input expected now but provided were not a high enough standard. And a lot of those, you know, have been improved over the last year. Obviously, the greatly increased demand and limited capacity is an ongoing challenge that won't go away. But engaging with those with lived experiences and different points of view and unique challenges has been really important and has borne a lot of fruit already. That said, the waiting list is still around 5 years for those who are red or priority, indefinite at the moment for amber green routine. I think it's fair to say. I'm not sure that the issue was that RAG was too complex. It was that amber and green didn't really have any difference in the current scenario. I think it's good that, as you said, people are saying it's great that I can stay on the waiting list, but that waiting list has to go somewhere for them to feel particularly happy about it. And if they're not a priority, it's currently meaningless to say that someone's on a waiting list. The changes to improve the tools to allow GPs to directly refer to avoid the platform where necessary, but also use the platform content, improve access to medication. These are all really good things that have changed over the last year. And the pathway is definitely getting clearer. GPs are more equipped than they were. There's a lot of really good stuff in there as well. But I think a lot of this has been too slow to pivot over the last year. There are still lots of gaps in these plans before us. We still need to move faster on closing those remaining gaps. And every month over the last year that we could have done this and didn't, and every month that we're still slow to move has a direct impact on all residents, including particularly those already waiting and those who will be waiting. Outside of this, all the improvements are generally really good, but we still have that pit full of people who think they're in a genuine waiting list. ICB owns that risk while people in that group experience any ongoing issues. Maybe it becomes a waiting list, fingers crossed. At the moment, it isn't really. But that's why the pre-diagnostic support is the critical bit of it, because you're going to be using it for 5 years on the priority waiting list, and it might be the only support that you get, but also might be the only support you need if you're on the routine list. And maybe the community support will be a good part of that, maybe not. But I just wanted to call out that there is still this challenge around the output of the tool and the concerns around that. And there was one example around empathy that gained a bit of social media traction. So I just wanted to read out the top 3 comments in terms of engagement in reverse order. It reads like, instead of assessing you, here's how you can mask. Yeah, cheers. I did that subconsciously for 37 years and it was exhausting. In other words, here's advice on how to be more like us, i.e. more palatable so that we can like you. Best of luck. And the top comment was this section written by a sociopath? Seriously, it's colder than liquid nitrogen, patronizing, and frankly lacks empathy. So I think things are much clearer. I think there's a lot better engagement with the community. I think people on the priority list have a much smoother journey. But with the waiting times not really coming down, the challenge we've heard around 40 assessments per month maximum, ADHD medication reviews, that bit of it is really, really critical. I think, well, I've expressed it already, but I think that the key part of that is retendering that tool and the content in there. And I think that needs to be something that is done immediately because it is a long process. In parallel, improving that tool. And I just wanted to make that point. It's not something that we can then afford to wait more months and keep slowly pivoting. We know what we need to do right now. But again, thank you for all the work that's been done. There's a lot, massive changes over the year.
It's a really good summary and thank you for that and your very balanced view and I accept and take everything that you've said. I think in terms of the next steps, the decision to move to a more permanent solution will be made in each of the places in North Yorkshire and in York via the place directors, senior leadership teams. The responsibility and the delegation still remains in those two places for now. This paper is the basis of that, so we should be able to get a decision quite quickly because we've not yet heard anything that might change that or can change that. And we are absolutely open to reprocuring the tool. We've said that we're open to anything that really helps. And I think even if we did, and I'll stumble over my contracting words here now, maybe Andrew will come and help me, but where you go out to the market to test it to see if there is anything else out there that even is possible. I don't want people to assume it can only be the profiler that we've got now. It might well be that there are other things that we can look at. And I know elsewhere in the country, they don't necessarily use this tool. So we are absolutely open to looking at the procurement itself might take a while. But that doesn't mean to say that we're not open to it. It's absolutely not fixed in stone that we stay with this provider.
And I guess that's my point, is that it takes a while to do that procurement. Being open to it now means that it becomes, yes, we will do that in a few months. Then there's that procurement process, and then there's a time taken to build on board the tool, whatever it might be. That's another year gone. So really needs a decision quick to then make a short time frame for that response. And it may be that this is the right tool, but if it is, I think there are some significant changes needed to make sure that people can genuinely use and access it, and that the output they get genuinely helps them, not just in terms of support through the universities and experts, but for them themselves, who are probably lay people who don't have a huge amount of medical experience and also don't know how to filter out which stuff is genuinely really good, which one's a medical model, perhaps outdated, etc.
Yeah, and this is where we really value our colleagues in the neurodiverse community being alongside us to sift some of that out. I'm certainly not an expert by experience, but I know a lot of people that are, and know more of them now than I did before. And they're really willing to help design what this should look like and be our sort of critical friends in anything that might come along in terms of other products to look at.
Yeah, I think we are still on a huge learning curve with these digital platforms. I draw a parallel with all the online consultation systems that we've introduced in primary care over the past few years. So they're not perfect by any means, and we'll only get them better by engaging with the people who use these platforms and listening to them and taking on board their comments. So that's really what we have to do going forward. Yeah.
Thank you. We're going to start wrapping up. You've got a brief point, Councillor Pavlovic.
Thank you. Groups that aren't going to access this, that are massively overrepresented within with neurodiversity, are people in hostels, people who are homeless, people who are in prisons. How are you reaching out to them? Often don't have GPs, never going to be able to access your services, but they then bring with them a whole range of other complex needs. So, I mean, it's great that you're working with the universities and everybody else that have got the capabilities of doing that, but there seems to be this massive gap.
I think you're right. I think you're right, and not all of those services are commissioned by the ICB, so prisons aren't, for example.
No.
So yeah. So that's why we don't want to make this just a health-led process and service. We want it to be a whole community-led, which includes all aspects of the community, and especially those harder to hear groups that are most unequal in society. And we've got a lot of work to do, most definitely have.
Thank you for that. I'm going to sum up in a section, but I just have one question of my own here about the figure 1 on page 3 in the report. And to try and make sense of the context, what that tend to suggest is that the number of people being referred has dropped since last May. Is that correct? And do you think that reflects peak demand as a result of COVID and what's been happening in the past few years? Or is it a reflection of people giving up on the process? What do you think that represents, that dramatic drop? And is it part of a longer curve going forward?
I think that remains to be seen. I think if you notice where the dip is on that chart, it's at the point where we introduced the new pilot. And I think at that point, there was probably a lack of clarity amongst our referrers as to what the pathway looked like, the new pathway, the new referral criteria. And I think that's probably just an artifact of introducing a new system. I think Liam has probably got a better feel for what the current referral rates look like, but we're not really seeing a slowdown, I don't think. I mean, that chart mainly kind of illustrates the ADHD referrals have increased massively, which is having the impact on the ADHD assessment. So even if there is a slight tail off in referral numbers, I think Liam will probably confirm that that doesn't reduce the workload, because the more ADHD assessments we do, the more prescribing we do, the more the workload goes up in terms of those medication reviews. So that kind of paints part of the picture. But I think as you can see from the chart, I think we're up to September 23. So yeah, that needs to be refreshed with a bit more sort of contemporaneous data, I think.
Thank you. I'll bring in Liam and then bring in Councillor Rose.
Yeah, trying to touch on that, the figure is actually direct referrals to the retreat. So it doesn't actually necessarily include any of the referrals that have gone through the platform, which are separately reported. So these are direct referrals to us. Obviously, when the platform was introduced in March 2023, then direct referrals to us as a provider slowed down because we weren't seeing as many as those referrals, we were getting them direct. So that's a reflection of that. I have updated some of this data today, only sent to the ICB this morning. But our peak was around about 400 a month in terms of total referrals, based on an estimate of about 60. I would say probably direct referrals over the past 12 months while the platform has been in place, we hover around the 80 to 100 mark at the moment a month. So we're still in above what our estimates were as direct referrals, discounting what actually goes through the platform itself.
Thank you for that. Councillor Rose.
Yeah, I guess the point for me is that wasn't plateauing before we got to the point where we introduced the new system. Old world was everyone got referred through this chart. New world is that most don't, and those who did go through the profiler tool, something like 85% or somewhere in that ballpark, that didn't then get referred to the retreat. So those numbers are still going up, and the numbers we've just heard then, and thanks again for joining, it's been really useful. But those numbers are higher than the number that can actually be triaged and assessed coming in every month. This waiting list is going up and up and up, despite the fact that's a lot smaller than the number that used to be there. And in the meantime, those who haven't been referred through the retreats are on this other waiting list that doesn't ever get seen. So the graph is slightly misleading if you look at it in isolation.
Thank you for that. A last point from Liam.
Yep, sorry, last thing from me. Just touching on the previous comment. Yeah, effectively, yeah, that's the problem. We when this service was commissioned, we estimated around 60 referrals a month. Because we ended up hitting around 400 each month, what we had is a risk in logging the referrals onto the system, ensuring who we've got on the system. And the second issue we had is the triaging of that. How do we triage that amount of referrals, and how do we understand the risk of people if we don't have the resource to be able to manage that capacity? So those were the two issues that were concerning for us as a provider.
Thank you, Liam. So I'm just going to summarise our discussion for your benefit from what I've picked up here. So we've discussed the digitally excluded. We've discussed managing expectations and explaining the pathway, helping and offering support before diagnosis. We've looked a bit at what change the pilot has delivered in terms of shortening assessment times and things like that. We've raised the issue of support at university and reaching out to homeless and those in hostels. And I hope all of that is going to help inform your work in the weeks and
Really
months ahead.
valuable, thank you. And still open, obviously, after this meeting, if people have thoughts and feedback they want to provide to us in this period where we've got to make a decision, would be really helpful.
Good. Thank you very much.
For your time.
Thank
Thank
you
you.
to you all. Would members like a 5-minute comfort break? Yes, so we'll do that and come back in 5 minutes. Is 5 minutes not enough?
No.
You're happy to crack on, but I'm just offering in case.
Yes.
Right, so we're ready to recommence. We now welcome Michael Melvin and Sarah Story to the table. And we move on to agenda item 4, Health, Housing, Adult Social Care Scrutiny Report, Adult Social Care Strategy. If you'd like to present that.
Thank you, Chair. I'm Sarah Story. I'm the new Corporate Director for Adult Social Care and Integration. So this is my first attendance at this committee. So I've met some of you. No doubt I'll get to meet more of you as time goes on. Thanks very much for having us here this evening. We've got a lot of work going on at the minute around developing the draft adult social care strategy, and we really welcome the opportunity to bring the strategy at this quite formative stage, really, to invite committee members to help us in that development and to hopefully share with us your feedback, your comments, your suggestions for how we might take it forward. Michael and myself, and I'll hand to Michael in a minute to say a bit more about the work that he's led before I came to York. But we're really, really keenly aware of the importance of engaging with people who use adult social care services, their carers, their families, our frontline workforce particularly, and all stakeholders, including external partners and internal partners and your good selves this evening. So that work does need to continue. And they've got a lot to say, actually. I was actually attending some team meetings just this week, and I've been out on a few visits with some of our workers and heard from some of the self-advocates in the city recently. Lots of people are really keen and really willing to share their views and to help us to develop this strategy, which is fantastic. We've then got the job, of course, of distilling all of that down into the final product, which we hope to be pulling together over the next 2 to 3 months. So I'll probably pass to Michael, if that's okay, just to say a little bit more about the work that's gone on so far to develop the strategy before we invite committee to comment. Thank you.
Yeah, thanks very much, and thank you for inviting us here. So I'm Michael Melvin. I'm the Director of Safeguarding Adults, and I've been working with colleagues over the past couple of months around preparing the work so far. But as Sarah said, this is very much at a formative stage, and we want to engage with a wide range of partner stakeholders, people with lived experience, and yourselves in terms of making sure that we get the approach right. And I guess that's because adult social care is it's one of the most significant functions that we have as a council, and it's critically important to many of the citizens in York, and getting that right is really important. And I guess, you know, a bit of what we've heard today is sometimes that when that isn't quite right, it causes considerable distress for people as well. So it's important that our approach absolutely maximises the best of what we've got. So the document which is in front of you, I'm not going to go through the whole document in great detail, but perhaps just talk a little bit about it. So where it is at the moment is that the document is taken from a lot of the work which is going on already. So, for example, the work which has been done through the Health and Wellbeing Board, through the Council Plan, through the JSNA, through our market position statement, and our workforce strategy. So we're really, in some ways, distilling what our approach is and what we said it is over the past few months. But clearly, it's also very much about looking forward and trying to make sure that we get the best of what we know, but also the best evidence from around the country. And we're doing this in partnership with a National Development Team for Improvement, who are supporting us with some of that evidence, which is really good. You'll see within the document, quite a bit of it there is quite a bit of description at the front of that. Really interested in what your thoughts are. The reason for including that is it feels like sometimes adult social care isn't the most well understood topic. There are advantages in trying to explain that succinctly, and there are some disadvantages as well, because the shorthand which we use for that means that not everything will necessarily be captured within that. But there's an attempt there to describe what it is that we actually deliver and the drivers for that and the legislation that underpins that. And there's also within the strategy something about the York context. So what it is about the activity that we currently do within York and the population that we serve and what that looks like. But also a description around some of the challenges which we face within there, which we're all very familiar with in terms of those issues around increasing demand, demography, cost of living issues, austerity, and the tough context, not just for us, but for the city as a whole and the partners who are working within that. So that sets the context from that. And then within there, there's a vision about how we want to take things forward. And again, that vision comes from a number of different places where there's been input from people with lived experience, staff, and from some of the national work which has been done around what good adult social care should look like. So it looks quite wordy at the moment. I'll give people that. But in terms of what it's trying to achieve, I think it's trying to recognise that, this is about people. People are expert in their own lives. They generally know what it is they want out of life, the things which they are good at and the things which they need help with. So it's the uniqueness of individuals, and also that individuals thrive within communities. And the more we can do to support communities, to support individuals, the better we'll work. And also in the vision, what we're trying to do is to describe what it is that we're trying to help people to achieve. So those things around leading, better lives, being more independent, trying to reduce those inequalities. And then something about how we're going to achieve that. And actually that needs to be in partnership. And it needs to be a way of working that supports people to live at home rather than institutions. And it's through that provision of affordable and safe and high quality services. So that's where we come from in terms of our vision. And then we'll also see within there are a number of commitments which we set out within there, which we intend to achieve by the strategy. And those are a series of themes which we think will take us towards enabling a better life. And those really focus around, again, the recognition of people's strength, the necessity to be of high quality in what we do in terms of that support, getting the way in which we practice, so that is the conversations that we have, making sure that those are really well constructed so we understand people's needs, and then helping make good decisions in partnership with people. Making sure that what we do is equitable and fair and safe. And then making sure that when we do things that we make decisions which are based on intelligence and data. And that if we do that, we should be able to achieve better outcomes for people. And that, again, enables us to use our resources better. And then whatever we do, we need to be able to do in partnership. So there are a number of those themes within there, which we think are probably the things which we need to do in order to make sure that we're able to deliver the ambition of the strategy. You'll see also within the strategy, what we've done with under those things is to have a set of statements around what it is that we're going to work towards. And that gives a slightly more granular level of some of the things which we would expect to see, which will then enable us to deliver that vision. It's not quite an action plan. It's these are the things which we would be able to do that. And then, we may well see a series of actions and plans which sit around the delivery of that strategy. But also we're very conscious that in terms of the assessment of the quality of what we do and the assurance around that, we have a new assurance framework which comes through the Care Quality Commission. So within that strategy, there is a way in which we're tying what we're working towards and the way in which we're approaching that to the expectations which exist through that quality assurance framework. So in terms of the paper itself, we're very, very happy to have some thoughts, ideas, questions today. You'll also see within the paper as well that there's a recommendation that we come back to this committee in terms of being able to present updates and then come back with a final product once we have that. So I'll pause there and happy to take any questions.
Thank you. That's very helpful. In a sense, as chair, I meant to just shut up and point to people to ask questions, but as members around the table will know, I am in the depths of all of this at the moment, and living through the kind of challenges that all of this is about with a family member who's very ill. So I thought it might be helpful just to offer a few comments at the start. The first thing is that you said you had a list here at the start where you were introducing what it was about because you thought it would be helpful. Exactly so, 100%. I would simply add to that list the falls prevention team, who are not actually mentioned here. And I say that because the key challenge, I think, for all of us is that although we all get old, most of us arrive at this situation either as people needing care or as family members with almost no understanding of what is available, what help might exist, who we could turn to, when we can turn to them. And the challenge for that, as I have experienced, is that leads to a situation where you can arrive too late. And that has repercussions, obviously, for families, for people who need care. It also has repercussions, I'm sure, for all the services. So it's in my context, a family member becoming more infirm. By the time all the services have kicked in, and we've been helped with attendance allowance and the falls prevention team and the reablement program and all those various organizations, we've actually arrived too late, is the reality. And I'm sure that must be the reality for people across the city. And I'm sure you're aware of it. And so for me, the biggest takeaway from the past few months has been how big the need is for us as a society to understand what it is we offer each other at a time when we can take that information in and hold it in our heads for the moment where we need it. So I suppose what I'm commenting on, first of all, really is just that list that you've got at the beginning is great. And the more that can exist, and the more easily that can be disseminated so the whole population understands, I suspect the better we'll all be.
Yeah, absolutely. Appreciate what you're saying there, and coming from your acute experience at the moment. And I think one of the things which we want to be able to articulate is that there's something which we want to do around having better, earlier conversations in some circumstances, because you're right, it's unusual for people to ring adult social care if they're not in some kind of crisis. And therefore, the information which we have out there, which enables people to have good conversations at an earlier stage, is very, very important. We do have some of that in York. We have things like the Live Well York website, but again, you're not necessarily going to look for it unless you're in some kind of difficulty. So again, that partnership work, the work we do with primary care, the work we do with our community services is really important.
Yeah, there are so many things going on. By the time I was advised that a day club might be available that would help end isolation, it was too late. My family member has never managed to attend it. And it's those kind of things that's fantastic to know these things exist. It's when we become aware of it and how we make use of it. But I'll pass on to Councillor Rose and then Councillor Steele-Ward.
Thanks. And Yeah, you've already picked up the one thing that I think is the only thing that I spotted that needs changing really. Just to call it, I think it's really good. I like wordy, so that doesn't, it's no bad thing. But the core bits in here I think are definitely there. The point at the end in theme 8 around we will aim to provide the right amount of support to meet people's needs and outcomes, appropriate support. You know, it's a unique area of the council in the sense that in a lot of other parts of the budget, if the budget increases by 25%, we can skip a grass verge cutting and find a way to do something. If you guys are 25% over budget, we go bankrupt as a council. It's a different world of challenging costs. And we heard at the beginning of this meeting a heartbreaking account of what happens if we don't get it right whilst we're cost cutting. And it's really good to see throughout pages 92, 91, keeping people well and safe from abuse, harm, or neglect, keeping people safe, joined up care and support, and those being a priority in here, because that's how we manage to, you know, avoid those situations when we are trying to provide the appropriate care. There's a lot of other good stuff in here. I think there's a lot of specific small bits missing, but you can't cover everything. And I think the key one is flexible support in theme 2 for making sure we're accounting for everyone's unique individual needs, of which there are many, often complex and overlapping. But the big one for me is I couldn't see anything about communicating what adult social care is and does. The only place I can find anything related to communication is about specifically unpaid carers. There's one sentence about that, but exactly as I said, that list of what it is really useful. And when you talk to the average resident, and us as councillors do it a lot, there's a vision of what the council does, and there's kind of like and also an NHS nebulous something over there. The council does some stuff, and the more that we can communicate that, the easier it will be to get people understanding what's available for them and get their needs met sooner and cheaper and better, but also to support their respect for the council for what we do, and it actually helps with everything else the council's doing as well for them to understand the huge amount of complex work we do in this area. So I think it's really good, and that page is a really good one pager. How we communicate that to the wider public is a big ask, because if I'm not impacted, why am I paying attention to the minutiae? But you know, I just want to applaud that work.
Yeah, thank you very much. They're really helpful comments, and I think I would agree that there's something about making sure that our communication is right around this, and that we get the messages in the right places, so that people who aren't necessarily immediately seeking them, they're more obvious to people.
If I can just add, I think for people who are fortunate enough never to need adult social care support, many people have, as you say, no understanding really of what we do, and actually that's great. If you never need support from adult social care, that's absolutely fantastic. But I would really invite all of us and citizens in York to really start a conversation about what it means to live well, to age well, to die well, and what sort of support people might expect or want or need, and to think about having those conversations as soon as possible, so you can talk and think about how can you potentially adapt your property to mitigate the disabling impact of the environment if you're born with or acquire an impairment early in life, and what sort of adaptations or equipment or technology or changes to how you live might you need to be thinking about well in advance of when you might need it. Nobody really wants to think about what might happen if you suffer a serious health condition or an accident. Nobody really wants to think about getting old, actually, but it happens to us all. It is inevitable, and I think it's really important that we start to have those conversations as widely as possible. So I hope this could be the start of more of those conversations, so that we can share a bit more about the really important statutory responsibilities that the council spends most of its money on, and why we can't reduce some of that, because we do have to still meet some of those statutory responsibilities. But even if we didn't, I would want us to be a council and a city that looks out for and supports people with disabilities, elderly people, people with impairments who really need that, because we should be putting those people first. That would be my view. So I think even if we didn't have those duties and responsibilities, we should be talking about it, and it'd be really, really good if we could have a think about how we might share some of that information a bit more widely. Thank you.
Thank you. Yes, councillor Steele-Walshaw and then councillor Burton. Oh, I'm sorry, the councillor Runciman and then councillor Burton. So,
I think you.
yes.
Thank you, Chair. It does carry on from councillor Vassy and councillor Rose's points about, and it's within, we talked about people who make referrals are generally at a time of crisis, distress, and within that, around 8 out of 10 aren't accepted, and that goes further into understanding what adult social care referrals are. And there was a mention of other organisations, but it doesn't say what other organisations. I think if there was an explanation maybe of other organisations that might be able to help and support, other not even necessarily naming all organisations, the type of support and things, and it just comes down to understanding, doesn't it? And that people, again, as councillor Rose said, have unique needs within this that can be met at different levels, but I think social care is just something, it's a go-to, isn't it? And a name that people are aware of.
Thanks very much. And it's, you know, I think it's really interesting that you've highlighted that issue of, you know, 80% of people who were assessed don't necessarily go on to have a commissioned adult social care service. And I think there are things which we can do about that. So I think part of that's right. We need to better describe how that support then happens, because people don't contact us for no reason. But also in terms of making the most of our staff resource and giving them manageable workloads and the right tools to do the job. Really what we want is that for people to be able to access the support which they need without necessarily having to go through an assessment process to access something which they might be able to access if we had those better earlier conversations. So that is an area which, you know, I would hope we might be able to change in the future.
Councillor Runciman.
I just want to say, before I ask my question, that I read it with great pleasure. I think it's a good strategy. I realise it's a developing strategy, but thank you, Michael, and Sarah, who may have had a small hand in it.
Okay, no.
I want to ask you the difficult question, which is theme 6. We're all very much prioritising the people in the system, and that's absolutely right. But we know too that CQC will look at data collection and intelligence, and you've rightly acknowledged in theme 6 that that is a weaker area. I wonder if you could just outline how you're seeking to improve it.
Yeah.
So evidence-led or evidence-based practice is really important in social work, and I think in the decision-making actually of a council and of our department. So we recognise, particularly when the budget situation is really tight, that we're going to have some difficult decisions to make. So it becomes even more important that we've got the right data and, really crucially, intelligence and analysis of that data to get to the point where we can offer advice and support to members who might be making decisions, but also to make sure that every individual social worker is utilising the evidence available to take those decisions. So knowledge and evidence comes in many forms, as we know. We do need to make sure that we offer appropriate training and support to our workforce so that they can research, so that they have the ability to use their reasoned judgment. So that does rely on data and information and the ability to look at, for example, casework, legal precedents and examples, as well as that good practice that we talked about. And there's a lot of data analysis and information that's available already nationally. So through, for example, the LGA and LGA Inform, the local ADAS networks, Association of Directors of Adult Social Services networks, and indeed through some of those networks, there's actually a developing approach to considering how we collect data, how we use that information, and how we collate that in a really consistent way to meet some of the new needs, for example, where the Care Quality Commission are asking us about things like waiting lists and waiting times, and the Department of Health and Social Care are asking us for data around similar things in relation to some of the individual grants and funding that they've provided to us. So that is quite onerous in terms of some of that data collection and reporting, and some of it is quite new. And you'll probably know that if you went to 50 of the councils up and down the country and said, how are you measuring that particular thing, you'd probably find 50 different ways of doing it. So trying to get to the point where we've got some consistent approaches, but we're also sharing some of that workload and sharing some of that good practice in capturing that information evidence is also really important. There's no doubt that our capacity within our department and within the council is lean. It's limited and lean, not in terms of motivation, willingness or skill, but we're quite a lean council generally, I think. So I think we do need to also take some decisions for how we support our business intelligence teams and people who work on some of our systems to make sure that we're really using the potential of automated reports to its fullest, and also being really, really clear about the priorities in terms of that data collection and evidence that we need to pull together. So I guess the answer is it's a work in progress, but I think it's a really important element to include in that strategy. It becomes even more crucial as we move towards some of those more difficult decisions in terms of funding allocation and resources. Thank you.
Councillor Coles, was that supplementary or no? Okay, so I'll go to Councillor Batson.
Yeah, thank you for the report. I've got quite a few questions that I've come across. I think it's good to have it all in one place like this. And I'm coming at it from the point of view of a disabled person, not necessarily older, but also from an older person as well. And having had experience and still experience of elderly relatives with this. So I noticed you put on page 94, we will promote and improve direct payments, individual service funds to maximise people's choice, controlling, planning and managing their own day-to-day care and support. So you have a plan already to do that, or it's through engaging through this that you will develop that to improve things?
Yeah, I think there is work to do to understand how we can improve the offer. You may be aware or may not that it is a legal requirement for us to offer a direct payment under most circumstances. But we do need to make sure that we've got the right support for people to manage a direct payment to fully benefit from the autonomy and hopefully better outcomes that they might get from that. And it can be a bit of a scary process, I think, both for people taking a direct payment as well as some of our own workforce, offering them and describing them and supporting people to manage them. So I know that we've got colleagues who've been working on that so that we can probably within the next few weeks bring forward some of the prioritised actions that we want to take. I guess my immediate view is I can see that there's work for us to do. That's probably a good thing, that I can see there is work for us to do and we can make an improvement to that system and process. But yes, we'd very much like to hear from people who perhaps have had experience of taking and using direct payments in the past or are curious about that option now as to what might be helpful to help us to develop that programme of work. Is that fair to say?
Yeah, so that's absolutely fair to say. It's a work in progress. So we have a system for direct payments. So we have a system at the moment for direct payments, but there's a lot of improvement that needs to happen within that. And I think key to that is listening to people who have the experience of using direct payments, what that's been like, but also engaging more widely with people in the adult social care world who might benefit from them. As Sarah said, work's ongoing, and we'll bring forward some proposals around that.
Yeah, and you can sort of maintain some sort of flexibility. So for people who do want to manage their own direct payments, because there can be problems with carers, certainly for LGBT people. I know I've had really severe problems with carers being very judgmental and needing to change. Not necessarily in York, but just generally that can be an issue.
Absolutely. And I think those issues around making sure that we have the right values within the workforce more generally are really important to us.
Yeah, and then, sorry if I'm okay, just to carry on, I'm sorry about this. A supported and valued workforce. I know to me, fundamentally, but certainly for adult social care, the workforce are the linchpin of everything, you know, and I know that there's a shortage of carers and they're so low paid. And there's also a shortage of money in the system. And I think what you're saying about supporting the workforce is absolutely right and has to be, because, you know, you've got to treat these people well. I know that it's outsourced as well quite a bit. How are you going to solve this awfully difficult problem, really? That no one else seems to be able to.
I mean, I'm not here with a solution actually to a national and very long-standing challenge. But I do speak as somebody who started out working as a care assistant just a few short years ago. And what I would say is the esteem for the sector, the pay, the terms and conditions haven't changed significantly over it's 26 years actually since I started working for a council as a care assistant. I don't think things have changed hugely. I don't think that we get necessarily enough focus and respect for the workforce. Again, I would really, really hope that we could encourage all of us and people within our city to consider the value that workforce brings and the really difficult circumstances that people work under. And unfortunately, we're in a position where you know, the funding that we've got allocated to what we spend on care is really, in my view, insufficient, wholly insufficient actually well, I don't think you could ever pay care workers what they're worth, just to say that. But I don't think we're probably anywhere near that nationally. And again, I think there's a lot of work for us to do to get to the point where we can understand how we can fully support people who might be interested in a career in care, whether they're going to, you know, end up being a corporate director or not. You know, to kind of think about that as a career and feel that they're going to be valued as part of that. And I think we don't have the answers, but hopefully, if we can consider how we develop our career pathways, how we work with NHS colleagues, again, both locally and nationally, how we understand what we could do to improve training and terms and conditions and support, you know, whether people work for independent organisations or for councils, we would hope to, you know, to raise and improve that parity of esteem for the care workforce. Sorry, one final point, this is apologies. You know, people may see their social worker once a year, they may see a GP a couple of times a year, they'll see their care worker every day, sometimes several times a day. So the opportunity for people to have an impact on someone's life is really significant. And yet again, you know, they're our lowest paid and probably least regarded and most invisible probably sector of the workforce. So Mark and I and our senior team and all of our colleagues, we really value that workforce. And when we talk about workforce, we're not just talking about the people we employ, we're talking about putting our umbrella out over the sector and understanding how we can work with all employers to improve that position. We're not going to solve it instantly, and I think it's a really long-standing challenge, but I think we do need to be talking about it a little more.
Yes.
Councillor Cars.
I've
Sorry,
got a couple more.
Okay.
Oh, sorry. It's very close to my heart, this. So going on from that, because there's the section on unpaid carers, and there's been this huge hoo-ha about the overpaying carers and that, you know, and it's a terrible situation. I don't know if it was on Newsnight this week, whether, you know, people who are they're getting carers allowance and they'd gone over the threshold, having to pay it back. It's a terrible situation. And I just know that unpaid carers are doing the most amazing job, propping up so much, and we'd be in a much worse situation without them. I know I don't have to tell you that, but for those who are thousands of people watching this webinar, it might be worth making the point, you know. Yeah. So it says here about us accessing respite, basically providing timely access to high quality replacement care for short breaks. It's fantastic, but it's really hard in reality, isn't it? And I think all the goals in here are brilliant. I just worry about how it's going to be possible to implement it in this current climate. And also with cutting down on fees to private care homes, well, I think fees in both the private sector and the charitable organisations are really high, understandably because of the care. But what worries me is the profit involved in the sector and how that the money is not necessarily going to the people who it should be going to, the carers and the person who's receiving the care. So maybe that's a bit too complicated a question, but it's this whole thing of money, carers, unpaid.
I'll have a go. So we've got another of our statutory duties as a council is to consider best value. So we do need to, we've got a fiduciary duty to make sure that we spend our citizens' money well. And actually we're often spending their money as their contribution towards the cost of their care, because obviously, again, the majority of people will make some contribution and a lot of people will pay the full costs of their social care, which is another thing that people don't often realise. So we've got that responsibility. So we do need to consider, whether what we're buying is effective, economical, and efficient, and make sure that we're getting the best outcomes we can for, every pound that we spend. So it's really important that we, do that work around good procurement, that we commission on an outcomes focused basis, and that we work with the sector to understand the market costs. And we've got some other duties under the Care Act as well to manage that market, to signal the market, to work with care providers to understand, how we can support with things like training and development and so on. So it is really challenging. And I think you've probably hit on one of the core challenges of this document is we're probably not going to be able to do everything there, or at least not straight away. We've probably got a level of aspiration and ambition for people with disabilities and elderly people in our city that probably outstrips the level of resources we've got available. So we need to, we need to consider how we prioritise within that. Unfortunately, we will have to do that. And I would say that supporting unpaid carers is very definitely a high priority. People may disagree, but we know, as you say, the cost of replacing the care that unpaid carers deliver would be astronomical. We simply wouldn't be able to do it. And neither would we be able to get the very personalised, again, an outcome focused approach that family and friend carers can deliver. I was really enthused actually to see the level of support for carers in York. I think we've got some fantastic support. We can probably do better. And again, I'd be really keen to hear from people who are carers or have been carers in the past as to what else we could do, what else might help. And again, some national challenges around things like respite care. It's really difficult to get pre-bookable short breaks, for example, because of how most care homes manage their beds. They're more likely to want to fill a bed with a permanent resident than perhaps keep that open for short breaks. But there are things that we can do in that space in terms of how we commission some of that respite that we can consider perhaps doing differently. Sorry, Michael's not getting much of a word in here. Did you want to add anything, Michael?
Just to say, absolutely, in terms of unpaid carers, absolutely invaluable. And I think, again, the context which we're working is that caring has become more expensive and more difficult for people. And some of the societal issues we've got around austerity are impacting carers more. So it's really onus on us, not just within adult social care, but as a city more widely, to support carers in our communities. And because carers, they're our friends and our neighbours and our family. So absolutely, there's something about making sure that we look after ourselves within this.
And supplementary to what you've said, you mentioned carers allowances. I would just flag up attendance allowance as well. The council were fantastic about helping my family understand about attendance allowance and helping us fill out the forms. To discover weeks later that the same kind of challenges exist as for carers allowances, that your loved one goes to hospital and suddenly you're not meant to be having attendance allowance, so you've got to advise people, and then you can't get through because there's no one at the end of a phone. Maybe some help there for people going through the process would be helpful as well, just so they properly get to grips with the challenges that are going to be involved.
Yeah, I mean, helping people navigate some of those, you know, national benefit system processes and understand, you know, what words and phrases they need to use and what's important in terms of evidence. I think that's really important. And there've been a couple of quite high profile safeguarding adult reviews recently over the last year or two around the really sad deaths that had as part of part of the person's situation, a sudden withdrawal of benefits where people actually found that because they weren't well enough or able to attend an interview, perhaps their money was stopped, and they were kind of signed off as not being able to engage or not engaging. I think it's really important that we work with partners at DWP and others so that we can help people to understand the needs of people with disabilities, sensory impairments, mental ill health, and why they might find it more difficult to engage with that system and process. And I guess, you know, we can do so much from an adult social care perspective to support and signpost. But again, I'm aware there's a lot of really great community resources and a lot of really great hardworking individuals in the volunteer sector and elsewhere who are doing some of that tireless support as well. So I agree, it's really challenging, and there's probably more that we can do within the city as well as within adult social care.
Yeah, just in terms of support for people
Absolutely.
in their need. Councillor Coles, then Councillor Baxter, then Councillor Evans. Oh, it's a supplementary to that. Oh, sorry, yes, okay.
Sorry.
Yeah, that's okay.
Chair. Yeah, just as a supplementary to that, that is something that we're looking to support. We had last year we did a pilot of a bus that went out into one ward, and over 9 sessions there was an additional £26,000 of attendance allowance claims that we were able to support people with, and we're really looking to extend that across the city. So those are the types of things that I think we can support our colleagues with as part of financial inclusion and the communities work. So sorry, I was just putting one of my other hats on.
Yeah, no, that's
but
fine.
I just thought it was a really important thing to say, that we absolutely recognise that we need to be able to support people to fill in some of these more complex forms, but to fill them in where they're living, as opposed to expecting them to come to one of the organisations or agencies or come to the council for that sort of support.
I think it was a 17-page form for a start, which I think some people would very much struggle with.
They are absolutely complex, and that's why having people to support you to fill those in is absolutely vital, and you know, we were well aware that that support was needed.
Yeah, and it slightly offset the fact that one of the first things we were told is not means tested, so it's easier. But it's a 17-page form. So it's those kind of things that some people can navigate easily and other people will struggle with. Councillor Coles.
Thank you, Chair. Just a couple of things I just wanted to say. One was, it's interesting how a number of us have reflected on this document. I reflected in exactly the same way when I read it, that, oh, this is great, it's really clear, it's set out really well, because we are used to reading council papers. And actually, if you're used to reading council papers, this is a really clear and interesting thing to read. I think if you apply a lens, a different audience lens to the document, it's probably a much more challenging document to read. And so that would be, I guess, one of the things that I would be saying about this document. It works really well for us councillors, doesn't it? We're all singing about how wonderfully clear it is. I had a meeting yesterday with the adults with learning disabilities, the People First in New Earswick, and they were complaining very vocally about how inaccessible a lot of documents that come out of the council are for them as individuals, but also just for their carers and the people who support them in their lives. So I just think that's a kind of wider plea, that when we put out documents, particularly around this kind of area, that we do so and is accessible, we think about the accessibility of it in every sense. And then the only other thing I just wanted to say was to pick up on and a couple of people have talked about the support and valued workforce. I just think we should we absolutely have to celebrate and value the workforce that we have, because we have to keep it and we have to preserve it, and we then have to build on it across the city. Sarah is an absolutely living embodiment of a career pathway that starts as a care assistant and is now the corporate director for adult social care. We should be really proud as a city that we have someone in that position who has started as a care assistant 10 years ago. 7 and is now our corporate director for adult social care. And I think it really shows in the way in which she's taken the approach she's taken to the role, that actually that is that lived experience of doing those jobs that kind of shines through some of that. And then equally, Chair, if I may, I don't know whether you're actually an unpaid carer for your family member, but we have thousands of unpaid carers across the city. I was at the Carers Action Group today with the Carers Centre. Loads of stories every time I go. If anyone hasn't been to a meeting of the Carers Action Group, it is absolutely worth attending, because the stories that people tell every single time, they're always slightly different, but the themes are the same, about the need for clear pathways, the need for clear communication, the respite breaks. All of those things are really, really important, and you just know that these are people who are wanting to do their best for their loved ones, and they just need the system to be slightly easier. And it is our job to try and just make that system slightly easier, so that their journey through it, in and out of hospital or in and out of care packages, whatever it might be, is a slightly simpler one. And you will be one among many across the city and around the council who will be fulfilling those roles. And I think we should be grateful to you, just as we are to the officers for all the work that they do, from the corporate director right down to our care assistants who are working across the city. So yeah, we absolutely need to sing from the rooftops about that stuff as often as we can, because that is how we will build and value that workforce.
Thank you for that, Councillor Coles. Is your point supplementary to that? Yeah.
Yeah, I just wanted to, echo those points entirely, and coming into any papers when you're a new councillor or as an external person, a lot of things just don't make sense, and particularly when it starts to verge on the edge of medical, there are words there were words on the previous agenda item, even after back and forth with the ICB, I was still going, I don't know what that word actually means in this context. I know what that word means usually. And I think that it is important that we're making sure we know what the audience is, and the minutes of this meeting won't be accessible to the average person, but anybody can become suddenly a carer or be invested in this for a variety of different reasons. And I wonder whether, rather than trying to cater this document to all audiences, where you might lose the right word, the precise word, in favour of something that's more accessible, perhaps less accurate, that something as important as this document, and frankly, I think our adult social care strategy, not necessarily the document, but the strategy is the most important thing that we do as a council. Maybe having that, but also having a version that is more accessible in addition to that might be a slightly better way of doing it. But it was just a thought.
Before I pass on, I would just add a little supplementary thing to respond to what you said, Councillor Coles. I think maybe the document would be helped just by having 3 or 4 case studies that showed people going through that process with their families, because then that changes it from high-level talk to, here's a situation, a person is these conditions, they engage with the council, they then speak to the reablement teams and the community nurses, and this is how it all works, this is who they've been put in touch with. I think just 2 or 3 case studies would really make this resonate more easily with most people. I'll pass on that.
It's a really helpful suggestion.
Okay.
Yeah, I sort of come at this from 2 points of view. As growing up, I cared for my mum, and my dad also cared for my mum, and we were unpaid carers. But also I have worked as a carer in York, in Marjorie Waite Court, Auden House and Glen Lodge, and they're brilliant places. And sort of going back to the supported and valued workforce, sort of talking about training and stuff, the training that I received was definitely not adequate. I mean, I hadn't had official training to be a carer. I'd learnt it having cared for my mother. But, you know, the training that I had, I was just thrown in at the deep end because simply the other people who were trained didn't have the time to sit down and go through everything with me, which was totally understandable. And I just wonder how we can have, you know, I know we desperately need more money, but I just wonder how we can, you know, encourage people to get involved. And then once they get involved, have adequate training. Because it was really scary that on my first day, you know, I was utterly thrown in at the deep end. Thankfully, I had some background, but some people who wouldn't, they just wouldn't have a clue what to do, and everyone was literally running around the place, you know, and I was sort of following, trying to learn. But I think that's something that we desperately need to improve so that people have a better understanding, because you have people's lives in your hands ultimately. And I think, you know, it can be quite dangerous.
Well, again, so thank you very much for your honesty around that. I will take that back in terms of where we are with some of our extra care schemes and the training within that. But absolutely, that workforce piece of work is absolutely critical, because you know, people will be retained within services if they feel like they've got the tools to do the job, which involves the training, and if they can see they're making a difference, and if they feel like they're valued and they're well looked after and they've got a career progression which they can follow. So it's really, you know, and a number of those things exist, but probably not well enough. And so part of, you know, the strategy needs to articulate that really clearly as a priority for us.
Did I see your hand raised, Councillor Rose, earlier? No, it wasn't. Okay, fine. I had a few more quick points. You may choose to regard or disregard. But the first is this: the peer review that's just come to the executive makes the point in it that the council staff made clear to the peer team they wish to be involved in contributing proactively to corporate problem solving. One possible way of helping to address this builds on the request from staff of the viability of an ideas hub. And in the past months, I've enjoyed the company of community nurses, the reablement team, the falls prevention team, paramedics, care home, frailty unit, accident and emergency, every single person, to a man and woman, dedicated professionals, showing empathy, compassion and care for the people they were looking after. And my family is overwhelmed at seeing all of that and witnessing it. I've had many conversations in that context with people saying, how do you think this could be done better? What do you think the challenge is here? We're having a problem making sense of this, you know, telling our story repeatedly. Being suggested by one not to fill in a Herbert protocol. It helps people, it helps the police if someone with vascular dementia walks up. And then the hospital team saying, oh, you've got a Herbert protocol. That would hugely help us because it would help us understand the person who's in bed 38. And we've been through it so many times. And many different things have been said to me by different people, suggestions on how to make things more effective, more efficient. I'm quite sure Sarah knows all of this because you've come through the whole process. I hope we include in our strategy the commitment expressly to get the views of all those people, both within the council and in the organisations we work with, whether it's the reablement teams or, you know, all those people, in order to better understand where efficiencies can be made. And my last point is a response to what was said earlier about lots of different things. Child carers are invisible. We're talking about how we communicate with people who at a time when they don't need someone. And I was just wondering, is there a part here for us to involve schools in a different way? To maybe invite schools to welcome a care team to come into a class and describe what they do. Partly so that children have an understanding that parents might not have, of what to look for and what might be done and what services are available, but also to offer an opportunity to those children who at the moment may be coping with very complex situations, to know that they're not alone, to know that there are opportunities for them to communicate. Just another thought, you know, is there something we can do across the silos to engage differently with different people?
Thank you. They're really good suggestions. I think on the first point, in terms of engagement, again, we feel really strongly that we need to do lots more really to listen to people and hear what they've got to say and then do something about it. And that last bit's, probably the most important. But actually, since I started working in York, I've set up some regular staff engagement sessions, and I've been round. I started going around all of the team meetings and meeting our colleagues internally and externally. And as you know, those colleagues, they know what the challenges are, they know what the problems are, but they certainly know what some of the solutions are as well. So actually, I don't know it all, certainly not. And actually, the way you do things is quite different in different councils, and York's got its unique challenges and its unique strengths as well. So there's definitely a lot for me to do to listen to people and understand, from my perspective, what's important and what we should prioritise. And really, that's swelling on from work that Michael and the rest of the senior team have been doing over the last sort of 6 months or so to set up some of those regular opportunities for conversations and hear from people across our workforce and external partners how we can do more. We're also engaging, as Councillor Coles mentioned, with people first, who are self-advocates, people with learning disabilities or learning difficulties, who are very keen to support us with developing some forums and perhaps a partnership board. And certainly there'll be other groups and individuals in the city who I'm sure would really be able to share their experiences. So again, we should listen to people and hear what they've got to say anyway, but that's the core requirement in terms of how we operate as an adult social care team and department, and it should be as a council, of course. We can always find more opportunities to do that, and I think making sure that we're hearing from people who haven't previously had their perhaps smaller voice heard is really important, and people who indeed don't have voices at all, and understand what people can communicate to us in different ways. So that I'm really passionate about co-production and co-design and engagement and consultation in all of its forms at all levels, and we're definitely going to be working hard to make sure that we can carry that on. And actually, it's really valuable, and it does most of our job for us, because again, we don't have to do too much hard thinking to understand where we need to prioritise. The second point about young carers, again, we know that many adult carers don't recognise themselves as carers, and many young carers certainly wouldn't, and that can have a really big impact on a young person's life in terms of their ability to engage in social activities and leisure and the normal, friendships and relationships in schooling, and all sorts of things, that make a real difference in a young person's life. So again, we have a statutory responsibility to identify young carers and to make sure that we're offering support. And we probably can do more in terms of training both our internal workforce and partners and others to reflect on where we might identify somebody as a young carer and talk to them about what might help them in terms of support. And sometimes it's really small things actually that will support young carers or carers of any age. At the very least, listening to some of their challenges and understanding, how we can hear that and do something about some of those practical problems can be really helpful. But also perhaps signposting people to other support later on in life might be useful as well. So thank you, really, really good points.
Are there any more points people would like to make? Councillor Rose, last point.
Since the conversations are wrapping up, on the pertinent point of what we need to decide between waiting for this to be finalised or getting ongoing review and being involved throughout, I already said I think it's the most important piece of work the council does. If we improve the quality of adult social care and reduce costs, then the whole council thrives, and if adult social care gets worse and more expensive, then good luck to all of us, and good luck to the directors and exec members in achieving this, with or without the strategy document. But I think whatever we can do to lend support to this makes sense to me. So I'd certainly back the recommendation to have us involved throughout that process.
Yeah, yes, Councillor.
just want to say that co-production is the way to go with these things, especially with disabled people. I know, you know, nothing about us without us, and with old people as well and their families. You know, I don't think you can go wrong if you listen. So great to hear that.
So is this committee happy to receive regular updates on the development of the strategy? My feeling is the answer is yes, emphatically. So you know that.
you.
I think that's everything. If you've got it.
So I just wanted to check, James asked if we wanted to stay for the forward plan agenda item, just to see if there's anything you'd like us to add in terms of consideration of future adult social care items, but we're really happy to be guided by you, Chair, if you wanted to join that discussion or not.
Do you want to take us through that, James?
Yeah, okay.
Yeah.
Thanks, Chair. Okay, so yeah, so the work plan that you've got in your agenda packs, this is a draft for the upcoming year. I think at the last meeting, the committee added some items for June, July's meetings. So this has been drawn up based on things that would be coming regularly anyway, and the TBC items that were left on last year's work plan. So you've got a few items that are highlighted in bold where the things the committee has already agreed for particular dates. You've then got some things which are underlined, which are things that the committee had already flagged that it wanted to be coming to meetings, but where officers or partners have suggested those might work on particular dates. And I think that's largely it. There's a handful of TBC items left there. So just to pick up on what Sarah said, I think for adult social care, I think there are relatively few items on there coming up. So that might be one area that members would be interested in having more on. But I think it's very much kind of work in progress, I guess. So it's there for your consideration today, but as usual, we can add items as we go. So I think that was everything. Oh, one other thing to mention actually for June, at the last committee meeting, you'd added the homelessness future resettlement pathway for that meeting. Another suggestion that's been made for that one is a suggestion which I think is going around all the scrutiny committees to look at the pipeline of scrutiny proposals for the combined authority. So I think that's starting with corporate scrutiny, and then the suggestion from officers is that comes to each committee in turn for suggestions. So just to flag that, because I think that was the one item that wasn't an existing TBC.
And as set out, before I bring you in, as set out, we've got the 11th of September down for the next adult social care meeting. What would you envisage? Is that a good date to come back to us? Would you envisage giving us a report or an update earlier than that, or is that a good time?
I wonder, Chair, if we might want to come sooner in terms of the update and the development on the strategy that we've just discussed, or perhaps the committee might consider a task and finish group approach to that. That's just a suggestion, and then a return with the finished strategy at a later date. So there's probably some options there.
So you're thinking of coming back with the update in, just to make sure I've understood?
Potentially July.
In
Is that
July,
a busy agenda?
Okay, so we'll look at forward plan properly in a minute, but July is a very heavy meeting. June is a much less heavy meeting, but June is only 4 weeks away. So that's too close.
Yeah, I think that's a little bit soon in terms of progress.
Okay, well we'll sort that out at the end and then let you know. Sorry, yes.
As well as a general point around work plan, forward plan. I assume everybody's points are at this point, but the two things for me are, number one is I don't know what state the pipeline of the combined authority for housing will be by the 12th of June, but that seems very early for us to be receiving anything around what the combined authority is planning to do on housing specifically, or anything else that this scrutiny relates to. The only other thing was the July and September meetings. I know we've split them out as public health and adult social care. I was going to suggest that we also put back in an update on dentistry after the conversation we had previously and some sizable gaps in provision in York and what we're doing around that. But that's also public health. And I wonder whether they should both be public health and adult social care rather than one separate the other, because then we can move one of the public health things into September and receive the update in July that we've just been talking about. It feels like we're going to be, there's a lot more in public health on a regular basis, I feel, to rotate to that way.
Okay, well, let's just finish off agenda item 4 then and say that we've covered that, because we're actually talking about the work plan now and not about agenda item 4. So we're happy to, yes, I hadn't formally declared that was what we were doing. So let's just say agenda item 4 is closed. So thank you very much for that. And we're now talking about the forward plan, the work plan. Darryl, Councillor Small, you also had something to say.
I mean, I don't think the combined authorities existed for over a year. It shouldn't be a massive shock to them. The new mayor obviously will have their own views, but hopefully they'll have something sort of interesting to say. No, I guess my thing is just, it seems to have sort of slipped off, or maybe it was never added, but I mentioned before it'd be quite good to have an update on void properties. Given that there's already the item on the 9th of October in terms of revised housing repairs policy, could there just be maybe a note added to that agenda item that we'd like to hear an update on voids in York?
Okay, so I'm making a note of that, and I'm also thinking what you've just proposed there, that we don't separate public health and adult social care and housing over this particular July-September period, be a bit more flexible, which would then enable us to bring your update back in July.
Yeah, I'm also looking back at what was on future work plan in the past that we might not have covered. And we did have autism and neurodivergence strategy, different to what we had earlier, but the council strategy isn't on the forward plan anymore because it was going to come and then it hasn't come. So that I think would also fit into that adult social care, public health, July, September space, potentially.
James, did you want to say something?
Yeah, sorry, Councillor Rose. Yeah, I think the November meeting, I think, has got the title is slightly different, but that was the item that the public health team had suggested for autism and ADHD. I guess it's.
I guess there are the two things. The one we had today is about, and that's what this one here says, is about the assessment for autism and ADHD. What we were talking about more broadly is that strategy for neurodiversity across York that is ongoing. I don't know what timescales is best and whether that November is just the title's wrong and it is the strategy or not. But a steer for whether that should be middle of the year or towards Christmas, I think might be useful if there's any idea on what time might be best to discuss that. But happy for you to take it away with the chair and look at the timing.
I'll discuss with the real chair in between us and the next meeting. Councillor Runciman.
Just to say, on the 11th of September, we've got Home Care Commissioning Task and Finish Report question mark. I would have thought that's the place to put the update on the adult social care strategy, because that fits, I would have thought, with that. I don't know what Sarah would think, but it would seem to go in there and give Michael slightly more time to work on it.
If that works best for the committee, that's absolutely fine. We do have another item that we might suggest to come perhaps to the June or July meeting if you wanted to consider an additional agenda item. We've had recently in adult social care the benefit of a peer review supported by our Association of Directors of Adult Social Services colleagues. We're about to receive the report from that peer review that's focused on supporting us to prepare for CQC assessment. So that might be an item that might be considered in terms of supporting us to then develop the action plan in response to that. So again, if you want to consider if that's helpful.
So you're saying that you will have something ready in July,
yeah,
and it rather
can
than
be
wait and
flexible
lose
with-
time.
We can be flexible with the timescales for both of those items, I think. Yeah.
Okay, and councillor Smalley mentioned void properties. Councillor Pemberley.
Thank you, Chair, and correct me if I'm wrong, but I'm not sure this committee in this iteration has looked at housing management and estate management. As you know, a pilot for estate management was introduced in the last administration. I'm wondering if it's worth having a review of how that's worked. And any recommendations for different approaches that the committee might want to make.
Okay, I'm putting that on the to be confirmed items and we'll discuss with councillor Myers. And then we'll let everyone know where we are on that. And there's one other item on the to be confirmed list, that's been going on for some time, and maybe you are or not yet aware of it, Sarah. The external expert on reablement technology. We've mentioned several times that there are all sorts of technological innovations that could be helping in this whole area, and that it would be useful for us to get an overview of those things so that we have an understanding, a practical understanding. Part of the problem of always sitting around a table reading words is that we don't get our hands on the stuff of what makes a difference. So maybe after the meeting, Danny Myers and myself can sit down with you and see whether that might also potentially, if we're going to do something in July.
I was due to meet with Councillor Myers. It's been rearranged now, so I think we can discuss that and the home care task and finish item as well, in terms of how we shape that reablement technology piece. I think it would be worth considering some of our fantastic frontline experts in our Be Independent service as well, who know a whole lot more about assistive technology than I do, and they may well be able to point us in the right direction of we could do some practical show and tell, as well as receiving some papers which might be interesting. But I can have that conversation with colleagues and see what might be helpful.
Members are okay about me and Danny Myers sitting down and chatting it through, and then informing everyone with a view to maybe doing that in July. Brilliant. Are there any other comments people want to make on the work plan? No, I'm not seeing any. Okay, fantastic. So thank you very much to everyone. I will declare the meeting closed. Thank you. Thank you.